This is very much a network of people interested in improvement and research impact and making things happen on the front line. So it's my very great pleasure to introduce two of our Knowledge Mobilisation Fellows. This is a new program that we've been running. They joined in June. And they're just kind of, getting their feet under them. So it's really great to have Sophie and Lauren here today to talk a little bit about some of the work they're doing to really make a difference in women's health. So I'm going to hand over to them. And if you're interested in the Knowledge Mobilisation Fellow work, we'll also add the link to the website where you can find out a little bit more about them and their two fellows, Julie and Craig, who are also working in North West London to mobilise knowledge into practice. Thanks very much, Lauren and Sophie.
Thanks, Rowan. Hi, everyone. Thanks ever so much for joining us today at the Quality Improvement Network, which we are focusing on women's health and knowledge mobilisation. I do appreciate it might be over some people's lunch break, so feel free, as Nick said, to have your cameras off if you prefer while you munch your lunch, but also great to see your faces. We haven't got too many slides to get through today, and we're hoping for a really engaging session, so we will have some time at the end for some discussion, but any comments as we go through, please do feel free to pop them in the chat. Next slide, please, Lauren. So just to introduce, really, this will be a whistle-stop tour of the disparities in women's health research and also bridging the gap between evidence and practice using knowledge mobilisation strategies. But before we continue, let's hear directly from some of the women affected and their experience.
Endometriosis has affected every aspect of my life.
Severe pain, severe bleeding. An emotional and physical roller coaster.
My bowels and my ovaries and my womb were all stuck together.
It was so bad, I needed to have a hysterectomy.
I was told that I was just unlucky.
It's just your age, it's just your gender.
It took approximately 8 years.
17 years. 16 years of going back and forth to doctors and hospitals to get diagnosed.
It just makes me feel like I'm wasting my life.
Summed up in a
Right, guys, so on that cheerful note, go back to, and let me change this. Of course, there'd be technical issues. So anyway, just to introduce us, my name is Lauren. I'm a registered midwife and I lead the clinical trials research team at West Middlesex Hospital, which is part of Chelsea and Westminster Foundation Trust. My lovely colleague is Dr. Sophie Farland, who's a registered dietitian working in primary care, and she's also a research mobilisation lead and multi-professional education lead. So we're going to do a bit of a knowledge check this morning, see what you guys know about women's health and all that kind of jazz. So we've got 3 questions for you on Mentimeter. So if you guys are happy to get out your phones, go to www.mentimeter.com. There's the code just here that you put in, and then you'll be ready to do our short quiz with us. So momentarily I will switch screens to Menti, but the code is still at the top, so please do not worry if your fingers were not quick enough because you're eating your lunch. It's not a problem. All right, so I'm going to switch screens now. And as I said, do not panic. There's no panicking at lunch times. Oh, you lot were quick. We've already started answering the questions. I love that. All right, I'll give you lot a minute to get in. So it's what percentage of evidence actually translates into practice. So these are, we've done the hard work, we've delivered someone's project, we've delivered, not to do a midwife pun, we've delivered their baby, we've got the evidence. How much of it actually ends up on the shop floor for patient care in the United Kingdom? Give you guys a couple more seconds and then we will figure out if we're done. All right, 3, 2, 1. 14%. Yeah, So 14% of evidence translates into practice. So you can imagine anyone that delivers research or works in the clinical area seeing that research being delivered. It's quite upsetting, all this work we put in. Hence why Sophie and I have got a very lovely job trying to up that amount. All right, so keeping on theme, what proportion of public funding is spent on women's health research, do you reckon, in the UK? Again, we're all learning and I cannot tell who's answered what, so don't worry if it's one of my colleagues and I'm like, you should know better. You know, this is all about learning what's going on in the women's health research service. Oh, we're all a bit unsure. It's a nice little cascade here, which I like, very visually pleasing, if nothing else. All right, so 3, 2, 1. All of you are right, mostly 2%. Sometimes it fluctuates up to 5%, but nothing to write home about, really. 2% of the national funding ends up in women's health research when we make up a whopping sort of 50-ish% of the population. Right, last question. Talking about all this evidence, on average, how many years does it take for evidence to actually translate into practice? So of that 14%, how many years does it take for that to trickle through? What do we reckon? All right, I think that's most people that are on there now. So 17 years. So of that 14%, it's taken 17 years for it to trickle through onto the shop floor. And who knows if the evidence has changed by that point. Like, we're really, really behind the curve here. Like, who knows if by the time the evidence has come, the population's changed, things have changed, and actually it's really outdated already. So I will go back to the slides. And of course, it started from the beginning. Bear with me. Because why wouldn't it? Okay. Sorry if anyone feels a bit motion sick with me clicking through like this. Bear with me. Over to Sophie.
Thanks, Lauren. So yeah, hopefully with those Mentimeter questions, it sort of highlights really what we're looking at in terms of women's health research and the massive gap. So as we found on the Mentimeter, the only 2% of public funded research is focusing on women's health studies, but there's sort of a wider cost to women as well. So it's estimated it costs £11 billion from absenteeism from gynecological conditions per annum. So that's sort of our whole economy really, but also that women are diagnosed later than men for over 700 disease areas. So it kind of just shows the real scale of the problem within the UK and probably globally, which leads us nicely on to sort of what we can do about that, and particularly sort of what Lauren and I are looking at specifically. So before we go through sort of our projects, we will just give some examples really around knowledge mobilisation strategies. As Rowan said at the beginning, we only started our fellowships in June, so we're absolutely no experts, but these are some of the sort of things that we're working towards at the moment. So in terms of engagement and relationship building, since I've been in post within my fellowship, I've done a lot of work to sort of expand my network, so reaching out to people on LinkedIn, and that's been quite successful so far, but also tapping into the networks within the fellowship with the ARC, and Rowan, Laura and Ben. Thinking about what we can do to offer some of our expertise to people and also learn from others as well. So I'm sort of developed training which I'm delivering to clinical staff in North West London on PCOS, which again goes out to a wide sort of group, is communicated on a wide scale. So trying to really establish a better network, and I guess delivering the session today as well is all about relationship building and building connections. So hope to have some good discussion with you later. And Lauren's going to talk about her extensive expertise in transmedia approaches.
Okay, so I mean, I currently lead a women's health research team, so a lot of that is actually getting the word out there, what we're doing, who's eligible, and meeting people where they are to get the word out there, because not one size fits all with these sorts of things. So within my work, what I hope to do moving forward in knowledge mobilisation is I use a lot of different social media tools. So I'm on the Trust Comms for my current role at West Middlesex. So you'll find me on TikTok, you'll find me on Instagram, Facebook for them, just promoting what kind of research we've got going on. I've also been on local radio. The clip that I showed earlier was a Channel 4 piece, which I was also interviewed for. So it's just really about getting out there and meeting people exactly where they are. I tend to find, depending on the demographics, that TikToks or Instagram works better, because a lot of the population around here, they've got quite busy lifestyles, so they would rather watch and listen to something on the bus or on the train. And we've also worked with partners for patient information sheets. For delivering research, we've actually had them done as videos instead, for people that sometimes can't read their own language, or they feel more comfortable listening to information when consenting to various projects. And I'll hand over to Sophie, who is exceptionally good at this planning and evaluation malarkey.
Well, thank you very much. So I think in terms of experience to date, it's probably been mainly within sort of dietetics, but obviously within our knowledge mobilisation fellowships, we're hoping to expand and share knowledge and support other teams as well. And so sort of within PCOS, which I'll talk about a little bit later, what I'm planning to do is a systematic review to understand what the evidence base is currently, but then in terms of sort of service development, really thinking about how we can co-produce services and then also evaluate them comprehensively. So I will be tapping into Rowan and Laura's expertise with that as well. But I think in terms of what we've done so far within Central London and within dietetics was a lot around sort of PDSA cycles. When I developed the dietetic service here, it was very much a trial and error and iteration, a lot of stakeholders to get on board, a lot of different agendas at play, and needing to understand what we were working with really in terms of the patient groups and then the feedback. So it's quite a lengthy process of different milestones to hit, and also different things to evaluate in terms of qualitative as well as quantitative, to make sure that actually you are running a service that is constantly improving. So that's a little bit about what we've been doing so far and a bit of my background, but I will pass over to Lauren about knowledge brokering.
So knowledge brokering, I think we all do this without realizing it. We're basically making knowledge more palatable to people so they can understand it and utilize it. So on my day-to-day, I will go and speak to people and enroll them in research, or I will provide evidence-based care to women in a way that is understandable. So for instance, I'm asked a lot of the time, oh, did you design this research? Is this your research? And I'm like, actually, I didn't. And people are like, oh, then whose research are you delivering? The easiest way that I've come across it is to say to someone, do you use Deliveroo? Like, yeah, of course I use Deliveroo. Who doesn't? I mean, come on, we all use Deliveroo. But basically, I said, I'm like your Deliveroo driver. We've got a really talented chef that has created this gorgeous meal for you. There I am on the scooter bringing it to you, and that's the research. I'm delivering it to you. That's my role. So even things like that, and I'm currently doing projects around some of the more complex tests that we do in the unit that have come about because of research, such as a placental growth factor test to try and improve the outcomes of women and babies where preeclampsia is in pregnancy. I won't go into breaking down preeclampsia, but I use things such as Canva, walk around, do talks, that sort of thing, talk about traffic light systems, anything to get that knowledge digestible for people. And that kind of leads me on as well to the utilizing of technology. So in the trust, we obviously have trust comms, but I've said about social media, I'm going to be using a technology called Patient Knows Best, which I'll go on to in a moment about the work that I'm doing, but that can be utilized on phones and computers. So it's about utilizing the technology we have to meet people where they are, because not everyone may have a smartphone. Some people just might have a PC at home. Also, not everyone's got a computer or a laptop. They're quite expensive. People may only have their smartphones. So it's about making things easy to access in various sort of mediums. Now, moving that on, so I'm doing a few different bits and pieces at the moment. And as I've said, my expertise is in women's health, hence why I'm doing all this work in women's health. It would be very strange for me to do something in urology. Basically, the pelvic pain platform I'm looking at is going to be on Patient Knows Best as a care plan. Now, this is for those that are waiting for their initial gynecology appointments. They've been referred by the GP. Also, you know, can feel a bit more like you're in no man's land waiting to see that clinician. You just get a notification on your NHS app just saying you're on the wait list. We don't know how long it's going to be. Or sometimes it does say how long it's going to be and that time passes. It makes you quite anxious. The idea of this platform is so that people can see what they have access to in the community already, such as the Mirena coil is a treatment for heavy bleeding, or pelvic pain that gynecologists can recommend. You can actually access that while you're on the wait list should you wish to, and there'll be the pros and cons of that on this platform. Also, have you tried any other sort of hormonal contraceptive, or for your heavy bleeding, have you tried any drugs to try and stem the flow of bleeding that aren't a hormonal option if you don't wish to have hormonal options? And it's about educating people about what is available when they do go to the clinic, setting expectations, and also talking about the treatment options and giving a risk benefit in a balanced way, because with the rise of social media and things like that, we've also found that sometimes clinicians are being demonized a bit. This is to try and pull back some of the mystery about what happens at appointments. Also, patients will be able to track their symptoms on this, and they'll be able to fill out questionnaires that I'll put on there, which will be able to shape what it is they want from their appointment, and their clinicians will be able to see this prior to them coming into the gynecology clinic. So it could be the day before, the morning, the clinician looks through, pulls up sort of their tracker to see when their last period was, see what's going on with the cycle, and also see what's important to the patient so that they can really make it a patient-centered service rather than having to cover a lot of information which may not be relevant to the patient. I'm also looking sort of to create studies to address gaps in knowledge where it's been indicated that we need to do more work in these areas. So sort of going back to my research delivery, but also I'll be creating these studies. So I'm looking at a randomized control trial of a new novel treatment for lichen sclerosis on the vulva against the standard of care. Anyone that knows about this condition knows that there's not a lot of treatment for it. And I'm also looking at a pilot study to look at the acceptability of GLP-1 injections for women with a raised BMI, which stops them accessing NHS-funded assisted conception services. So they're currently 2 in the pipeline, which we're hoping to get funded for West Middlesex. And then kind of looking at what I'm doing, I really do want to do a qualitative evaluation of the things that we're doing, how it is to actually mobilize knowledge, and how it's been for the clinicians as well as the patients to be a part of creating these things. Because I think it's really important to look at the process as well, rather than just the raw numbers. And looking into the future, I'm keen to assist in the update of clinical guidelines when the research studies we deliver publish their findings. And I'm also very keen to join the project about embedding VTE effectively in the early pregnancy settings, both within the hospital and outside of the hospital. So enough about me and my fancy cartoons on here. It's over to lovely Sophie.
Thanks, Lauren. So as Lauren introduced me earlier, I'm a dietitian by background. I've been working in primary care for coming up to 3 years now, and developed the dietetic service here. And more recently, I started to realise that there were more and more women being referred in primary care by GP colleagues with the referral reason just for weight loss. But actually, when these women were presenting in clinic to me, a lot of them had signs and symptoms of PCOS or a diagnosis of PCOS. And there was a lot of dissatisfaction with the care that they had received. And so I started to look into this a little bit more and realised that actually it's quite common that women feel dissatisfied with care and the lack of services that are available, which led on to the all-party parliamentary group and the formal inquiry this year. But it's led to me to focus on this area for my my fellowship and some of my research work. So in terms of what I plan to do, I'm looking to do a rapid systematic review to assess the current quality of life questionnaires for PCOS population with a plan for amendments and iteration to actually meet the needs. So there's a handful of quality of life tools that have been previously developed, but that they seem to miss off certain domains, and that has been reported on in publications. And really, I guess that the goal of that is to actually empower women to take a tool to guide conversations with their GP so that they don't feel fobbed off, which is a lot of the time what they say. And that is well documented elsewhere. However, from a UK perspective, that evidence base is actually missing. And so what I plan to do is a survey and semi-structured interviews of patients to understand, particularly from a North West London perspective, how women experience their care in terms of diagnosis and management. And I also plan to repeat that process for GP colleagues as well, because I think a lot of the time there's not funding for services, and so I'd love to understand from a healthcare professional and a GP perspective actually what is it that drives a narrative of sometimes that women just need to go away and lose weight. So there is lots and lots of information out there around, and obviously with the new international guidelines and the NICE guidelines being rewritten, there's a lot more evidence, even though still limited, and there's some ethnic groups not represented properly, but it has started to develop to demonstrate that actually there is good evidence for holistic personalised care. It's not all necessarily about weight loss. There needs to be a mental health and psychological support element as well, which is really important for women with PCOS. And so I've sort of utilised the knowledge mobilisation platform and network to develop training within this area to try and change that narrative. So it's a two-course, two-session mandatory course for clinicians in NWL, and I'm working to try and get this CPD accredited as well. And really the aim is to just open up the conversation around latest evidence within PCOS in primary care, to support and empower healthcare professionals to actually have deeper conversations with women, with the view to hopefully improve patient experience. My plans for the future of that is really just to keep developing the evidence base using knowledge mobilisation strategies and a network, and to encourage engagement and development using transmedia approaches, but also to evaluate the impact of any intervention that I hopefully will be able to implement, and really think about the sustainability of that. I plan to work with the national charity Verity for co-production of resources, and also to guide service development of the quality of life tool. But really, a lot of women at the moment wait over 4 years for a diagnosis. Women are 3 to 6 times more likely to experience an eating disorder, 3 times more likely to experience anxiety and depression, and report dissatisfaction with care. And what I would love to move to is actually women feeling empowered, able to self-manage, have adequate support and resources available to them, and know that we are sort of providing that personalised holistic approach from a primary care perspective. Thank you very much.
Okay, so looking at women supporting women here, and we're looking at sort of the value of mentorship and community. So Sophie and I have really benefited from the mentorship that we're getting from the Knowledge Mobilisation Fellowship, the support also from clinicians that have really helped us and supported us along the way. And we're really willing and hoping to be able to pay this forward. So if there's anyone on the call that's like, oh, it'd be really good to connect you with someone who's interested in this area, or can you support someone that is very much trying to do something similar? We really do believe in bringing people up with us. It's not a case of climbing over others. So that's something we're both very passionate about. And we both really respect the work that's being done by Wellbeing of Women, and also the Alanthi Midwifery Trust. They do sort of funding schemes for those that are trying to improve outcomes for women, whether it be in gynecology or obstetrics areas. And we just really, really want to support others coming through, because it's meant the world to us to have other people support us coming through as well. Over to Sophie.
Thank you. So this is really on our slide before we move on to hopefully some really good engagement, but it's really just a call to action. So hopefully the session's been useful, but we would love to hear from you if you've got expertise in women's health, or there's things that you feel we haven't thought about. Particularly for me, this area in primary care, I'm still trying to understand what barriers are, and if anyone's gone through different processes in a similar area and would love to share that, I would love to hear. So also, as Lauren said, if you're sort of developing a program of study and you've got some expertise in different areas, we would love to hear from you in terms of women's health, and also just build connections. So I think Lauren and I have sort of developed our network over years of working in different roles and meeting different people, and it's just so helpful to meet more and more people, and sort of you never know when that name's going to come up, and it's really helpful to just check in and say, can I pick your brains on that? So thank you everyone for joining over your lunch break, and I hope you have found it helpful and useful. And yeah, any questions, comments, please do let us know, and thanks again for joining.
Any questions from anyone? Yes, very well done. Really well done. I'm going to go to Miranda first.
Thanks. Yes, thanks, Lauren and Sophie. It sounds like you've got a really interesting programme of work organised, and a very important one. I just wanted to go back to that figure of 14% of evidence translates into practice that you gave us at the beginning, because there is a huge and ever increasing amount of really not very good research out there, and a lot of it probably shouldn't be taken into practice. So I was just wondering, with that figure, what are you considering evidence? And a related question, how are you going to decide what knowledge should be brokered to the patients and the women that you're going to be meeting?
I'm happy to go first for some of that if you want, Sophie.
Sure. Yeah, feel free.
So when we were looking at the amount of evidence that's going out, we were looking at the quality of trials. So when you look at where that stat has come from, you're right, there is some really poor quality research that absolutely should not be out there. And the first one that comes to mind is a bit of funded research that assessed how attractive women were with endometriosis. That study does exist. I was scandalized. That should not be anywhere. But you can find it on Google. So that was looking at a lot of high quality research, and looking at other research. But for Sophie and I know we usually look through papers and we're just like, okay, so are we doing gold standard with randomized control trials, or are we looking more at qualitative and what is important to the women? So for me, what I'm mobilizing is definitely mixed methodologies. So we've got quantitative with qualitative, and a lot of the research I'm seeing coming through in women's health actually has a qualitative element that is embedded in it, which is beautiful. And that's usually looking at women's experiences of actually being on the trial, which is really interesting. There's a study called Unity doing that at the moment for fertility. So I know for us, we're very much looking at the quality of the research, but we're not just relying on randomized control trials for that, even though they're deemed as the gold standard. A lot of researchers are moving away from that now, so that people feel they can be involved in research without being blinded for months on end, because sometimes that does put people off. So for me, that's how I feel on it. I'm kind of blending it and having a good look and appraising the papers myself. I've just come out of a master's of research where I had to do that for my dissertation, so I feel like it's a reflex now. Did you have anything to add, Sophie?
Yeah, thanks, Lauren. I think much of the same, really, in terms of particularly in research in PCOS. We know that there are large ethnic groups that are not represented properly, and so some of the quantitative research and some of the figures there, actually they need to be considered with caution. But actually I'm focusing on some of the qualitative, which I think is missed quite a lot. And you know, think about women with pain, that actually they feel they aren't heard, and all of that. There's so much to say about that as well. So yeah, much of the same, Lauren. I think we had to do it on a bit of a case by case basis and look at actually the quality of that research, rather than take it as one.
Trish.
Thank you. I don't know if you've come across the Critical Appraisal Skills Programme, but there are some very nice, easy checklists there if you just wanted a quick tool to assess the quality of a paper. Thank you.
That sounds wonderful. Thank you. I'll look it up.
Thanks, Rada. Trish.
Hi, good morning or afternoon now, and thank you for that presentation, which was it's a subject that not many people get to hear about. As we know, it's women's health is not always in the forefront, so thank you for that. But also it sparked some conversations that I might want to have with my team around. We're doing some work with our gynecology teams at the moment, and there are some really good areas of good practice there that you were talking about, and it'd be helpful for me to contact you and get you in linked up with some of our team to just have a conversation about some of those pieces of work that you're doing, and maybe even given our population, which is a very diverse population in Northwest London, it might be helpful to have links with our gynecology team to see whether there are any areas that you can work with together.
Absolutely. Thanks, Trish.
Sounds wonderful. Thank you so much.
Katie.
Hi, I'm Katie, and I'm a pelvic health physio at Imperial, but I'm also doing a pre-doctoral fellowship. So
I recognised your face. I've
yeah,
seen you
I
at an
recognise
event.
you. I think we've met before. But yeah, just wanted to say hi and just thank you for all your amazing work. And you know, hopefully that 2% will slowly increase with the likes of you guys, and hopefully myself as well. And I just wanted to sort of add to the conversation around the qualitative research, because I've been doing some research interviews myself, and the depth and the quality of the information that you get is so much richer than always in the quantitative space. And what's come out of my interviews with people with neurological conditions is that kind of the advice and the conversations around sex for women is completely different to the conversations for men, and so that's sort of the direction that I'm hoping to take my research around, like female sexual empowerment, and like what we can do as healthcare professionals to empower women to enjoy sex. But yeah, I'm just keen to kind of be linked up with you guys and that your networks as well. And yeah, thank you for all your work.
Absolutely. Thanks, Katie. Yeah, let's absolutely connect afterwards. And I think same with you,
definitely.
Trish. Yeah, thank you very much for the feedback as well.
Any other questions? Just while I'm just wondering, I have a question. Do you think there is an issue with stigma here? Lauren had those beautiful images of the vulva and is that actually a reason why people are, oh, I don't want to see a vulva on slide? But there's a bit of stigma around that. Do you think that's an issue?
Yes.
Yeah, definitely. I mean, I know from my previous work in sexual health and reproductive choices, some of the women that come through to me, they were late teens to early 20s, some of them, and I would sit there and draw a vulva on here and reproductive anatomy, because some of them weren't sure how they'd conceived, and I was like, okay, so this is quite a good place to draw, by the way. But there is stigma around that a lot, and I do find once you do open up and have the conversations with the women, I mean, as you guys know, you see me and I sometimes have sparkly uterus earrings in or something like that, just to make people feel a bit more relaxed. As with me as a clinician, I don't need to be frightening, but there is another, I hate to say, you know, influencer, but there's Dr. Sese, I think her name is, and I've listened to her talk, and she walks around with a knitted vulva, which is breaking down a lot of barriers. But I do think that's another thing with women's health research as well. People are like, why do we need to invest in it? They're fine. Like, it's not a problem. So that's another thing as well. I think women are being wrapped in shame about having issues with their bodies. So they're not protesting saying we need more research in this area because of that shame that you sort of discuss and the taboo nature of some of these things.
Yeah, so true. Laura.
Thanks, guys. Such a good presentation, as I knew it would be. Such beautiful slides as well, as Rowan kind of alluded to. Really interesting, but really pretty as well. I was going to ask you both. So I know a bit about both your projects, and I know how much you guys have packed into the work that you're currently doing. But Sophie's raised kind of inequalities in a couple of ways here, and I'm just wondering, with the projects that you are doing, how will that impact? You know, will you start to try to account for them? Will there be special considerations that you make in certain areas? Is it an area that deserves its own, you know, research in its own right, I guess, probably, and you won't be able to tackle it all, but how might you approach that in each of your studies?
I think so where I'm based in just by Paddington, we've got 31 practices across 4 primary care networks, and so sort of our clinics are very diverse population group, and I'm lucky that within my research role here I sit with the BI team who have got data experts that can pull that for me. So what I will be looking to do within the survey and interview process is have as representative sample as I can, because I know that within PCOS, a lot of African American population are missed within the studies that have currently been published. We also have quite a large South Asian population here, which we know suffer sort of worse with their symptoms of PCOS, and so I'm going to try and focus on pulling some of that information out in terms of their qualitative experience. But then I guess also in terms of utilising the network with Verity, it's a national charity. They've got a large patient population. So I hope to be doing some of that work with them as well, so that I'm not sort of contributing to publishing even more information that doesn't feel representative of the population I'm trying to serve. Lauren, I don't know whether you wanted to come in on what your plans to do as well.
Sure. So with mine, I'm actually about to do an audit on the gynecology service, what women's presentations are. I'm discounting out of the audit, not because it's not important, but just because the data isn't for what I'm doing, the rapid access and the colposcopy service, as well as the fertility service. So I'm looking at much more the general gynae service, which, you know, covers a wide range of conditions, but not in those specialist areas. And as part of that audit, I'm looking at age, ethnicity, and postcode to try and see if there's any trends. Now, I'm based, if anyone knows where West Middlesex Hospital is, as much as there's Chelsea and Westminster, I'm over at the Borough of Hounslow. And typically with our pregnancy service, looking at the booking for maternity care recently, 47% of our women were Indian Asian. And actually, when you look at the South Asian community, it makes up about 60% of the women we book. So we do have a very diverse population. So I'm starting there. We also do work within community groups as well, speaking to our local religious leaders and women's sort of charity leaders to ask them what's the best way to approach them and what would be helpful, and do they want us to come out into the community to discuss these things. So I'll be doing patient public involvement as well with my pelvic pain groups, which will be those community groups, but also women that are already involved in research with me. And I want to make sure that I test my platform with a representative group before I launch it. So there'll be kind of like a test area to make sure that everyone can understand it. There is translation services available on that platform. However, I'm very much aware that not all women can read their own languages, and a huge body of text for some people can feel really, really overwhelming. So I'm going to be looking at potentially doing shorter videos, animations, using accredited AI to make sure that it is actually going to be saying what it's meant to say rather than a bit of Google Translate, which we all know can be comical at best and dangerous at worst.
Yes, quite interesting, isn't it, to think not everyone wants that textual information. Some people now, especially, I mean, I know I have another colleague here at the University of West London who is interested in film and how our language now, everyone just goes to YouTube, they go to film rather than going to text. So is that where we're going? Anyway, Ben.
Oh, thank you. So interesting. And thank you, everybody, for the really helpful discussion. My main point was just to say a bit of feedback to Lauren and Sophie. So I've learned so much about this topic from the both of you just over the last few months. And it was just really to kind of say thank you and compliment you on your style and the way that you present all of this information, because you do it in such a kind of kind, compassionate, thoughtful way that it really, really lands nicely with the audience. So I just think you are doing a really good job of already brokering that knowledge to people like me who really didn't know as much as you do about this topic. So thank you for doing that. And then also just thank you on the presentation today. And I think you can see from the number of people here and the questions that have happened, it's good to see the interest and hopefully lead some more connections and more work beyond. So that was all I want to say.
Thanks, Ben.
Thanks, Ben.
We do have a few things in the chat as well. Is the stigma related to women's genitalia or genitalia in general? And that's a good point, I think, because is it just generally we don't like to think about men or women's genitalia, that it's taboo and nobody wants to talk about it, or is it a particular it's worse for women kind of thing?
I feel like within the research, I heard a statistic, and Lauren, you might know this better off the top of your head than I do, but I was listening to a presentation. Actually, it was something along the lines of that thousands of publications that have been done on erectile dysfunction, but actually like only in the hundreds on menstrual blood. And I was just like, well, doesn't that just sum it up nicely? I think that's crazy, and we've got such a long way to go. And I think especially when we're thinking about the translation of evidence, the amount of time that it takes, and then the funding, all sort of just doesn't paint a particularly positive picture. So I'm not sure what other people think, but I think when I read that comment, that talk just really stood out to me.
Something that's just come up to me today, actually, I've just seen about the stigma related to genitalia and, that sort of thing. And it's World Contraception Day today, just to let everyone know. They're doing a little trolley around the unit. Now, they had key rings available, right? What do you think, you've probably just seen it, was available as a key ring for World Contraception Day in a maternity unit? Any guesses? What was on the key ring? A sperm.
Oh.
No vulvas, no uterus, no ovaries. And ovaries are easy. You can just do a little round ball. We got sperms. So I imagine Sophie and I over lunch one day could probably Google how many semen style earrings there are versus uterus earrings. And I bet there's more. And also on hen parties, I tend to see women walking around with willy straws much more than men are walking around with uterus straws. So I do think the stigma is around women's bodies, and there's a lot to unpack there, and there's a lot of good work going on. If I can find some good semen earrings, I might use them for my fertility study to make the men more at ease. I don't know. But yeah, I just think we've got a lot of work to do. And thank you, Ben, for saying that we're kind of putting it in a relatable, safe way, because that's definitely what we both feel is best. There's just no space for judgment when we're trying to educate people, even though I'm judging the semen keyring a little bit, I'm not going to lie.
There's also something in the chat about, are there any women's health hubs accessible in North West London?
There are.
There's a few, isn't there? But I need to speak to, I had a meeting with the NHS England lead about the hubs, and we were looking at having ones that are a bit more dedicated to purpose. And myself and one of the gynae consultants here are quite keen to almost have like a early pregnancy unit light hub, if that makes sense, because it's quite a long way for some of our women to come for regular repeat bloods and things with ectopic pregnancies. So it is something that's bubbling along in the background for us, definitely around this area. I don't know which ones you're aware of, Sophie.
Yeah, I know that there's one not here. I think it's in Hounslow. There's Wellbeing Women's Hub, but here in Westminster, I don't think we have one. If we do, I'm not aware of it. But I was speaking to Alid Reid yesterday, who's the consultant endocrinologist and the clinical advisor for NICE on PCOS, about really what does an integrated service for PCOS look like and what is the longevity of the women's health hubs. And I think because of different politics and guidance and uncertainty around whether or not women's health hubs are likely to be funded in years going forward, it's quite difficult at the moment to know whether that is the right course of action or whether we need to be looking and thinking about something else. So I think they are brilliant and a really good step forward, but yeah, I think with financial uncertainty, need to be thinking about different options to really provide the right care at the right time in the right place.
Any other questions? We've got about 10 minutes left. Anyone's got any questions? Nick?
Ryan, there was an earlier comment that says 2% of public research funding is spent on women's health. Any ideas what percentage is specifically allocated to men's health?
I will come back with that stat at the next meeting. I will look into it. Do not fear, it will be found.
Yeah.
Or Laura knows the answer.
There we go, Laura.
No pressure, Laura. Come on.
I don't know the answer. I had a point to make, so someone Google it. Surely in the background we can get it. I just had a point to make, more of a discussion point, because I think Ben makes a good, you guys have done such a good job of making this topic, really approachable and palatable. But I'm just wondering how much of a knowledge broker's job is to make something comfortable for other people. I think it probably is usually, but for women's health, it's like, how much do we have to work at, making things not scary or gross or, it more, I don't know. And I think that'll be a battle for you guys as you go forward, because I think it's a real balance. Like, people know women have periods, people know about menstrual blood, but people don't want to hear about it and say it. And it's whether or not to make it palatable and to mobilize knowledge. Is that an important thing to make it pretty and to make it, palatable? Or is it our job to push it forward and to really break the stigma in a different way? And I don't have the answer, but I'm keen to know how you guys would think you're going to handle it.
I think for me, I have come against varying levels of resistance in terms of, from a primary care perspective, and also funding and that sort of thing over the more recent years. So I think I definitely sort of transition up and down a spectrum of how forceful or not forceful to be, dependent on the context and the audience. But I think that's why there's a really important part around education and training for clinical staff, developing resources so they feel they're able to give patients something when they're coming to them, but also going, straight to the patients themselves and having a group of women that want to learn, and so that they can have those conversations and advocate better for themselves. So I think part of the knowledge brokering for me is around going to the different stakeholders that we're actually trying to facilitate change within, and making sure that everyone feels empowered and has access to the right resources and information. Because obviously my approach will change very differently if I'm approaching a clinical director or for some funding, to colleagues, to patients, or to carers or family members. So I think it really depends. And I think part of that is probably a really fluid thing that we're going to have to navigate consistently over the course of our fellowships, but also throughout our careers, I think. Lauren, I don't know whether you had anything that you wanted to
I think
add.
I'm in agreement with you. It's about that emotional intelligence to know who you're pitching it at. And that's not necessarily about making it comfortable. It's making it something someone can understand, and that they are receptive to having that conversation. Because I could go and be all fired up about something and speak to the wrong clinician, and they're like, get out. I'm not changing a damn thing. Don't come in being all fired up with me. Whereas I know there's one clinician on the call today where I myself suffer from a women's health condition that's really underrepresentative. I was really upset one night and I did say to them, how do you feel not being able to cure any of your patients as a gynecologist? It was a vile thing for me to say, but the conversation was at the right time for us to have that conversation. But if I'd gone to one of my other colleagues and said that, it probably would not have gone down the same way. So it's very much about pitching it. And it's the same with the women that I come across. We held an endometriosis girls' night in event here, which we basically stripped out the boardroom, yummy gluten-free snacks, and no one got a flare from endometriosis. And we had nice blankets, pillows, turned the lights down. And everyone felt comfortable enough to actually start getting fired up. And then people were like, well, actually, I work in Parliament. I can help you push this forward. This is ridiculous. What do you mean there's not a cure for most of these conditions? Or what do you mean that what my doctor offered me was all there is? I thought they were gatekeeping. And I'm like, they're not gatekeeping. They've got nothing else. And they're disillusioned because they've got nothing else to give you. They're just hoping for the best. And the thing is if we're not all aware of these things, it can feel like you're fobbed off and I think the transparency, I think we need to trust people with the information, but I think it's the initial conversations maybe need to be in a comfortable area so then people can feel comfortable with the uncomfortable truths and the uncomfortableness of the discussions potentially.
We've just got a few minutes left. If we can go to Katie quickly and then Nusrat.
Yeah, I mean, that's such an interesting conversation, isn't it? Also about like what's palatable and like, should we be trying to make something that's normal, like a palatable, you know, that phrase makes it sound like, I don't know, for men, we wouldn't try and make it more palatable for men. So, you know, why does women's health conditions have to be kind of made smaller or less? Anyway, that wasn't my point, but a very interesting conversation. My question was just about the pelvic pain network, because obviously, you know, we're all having patients that are like, for example, in our pelvic health service, like on waiting lists. I just wondered like if that was something that is accessible or is it still being worked on? Lauren, I don't know.
So my pelvic pain platform that I'm doing, it's going to be piloted at West Middlesex, and it's going to be specifically for awaiting your first appointment. So you've been referred through and you've got something that you can educate yourself with. If once I've surveyed women and clinicians at West Mid, they think it's beneficial, they think it's helpful, it's good for the right conversations, then I may cascade it potentially if it's something your area like Imperial would be interested in. We can then look to have it cross-site at Chelsea, we can consider Imperial, and we can grow it bit by bit. And also I think it would be very interesting to have your take on it, Katie, as a physio, because pelvic physios are like the holy grail. A lot of endometriosis services have just got, I don't say just, they haven't just got, their physio is a general physio rather than a specialist pelvic pain physio. So to have your input with potentially things that women could be doing themselves at home that are very, you know, low risk, we don't want anyone injuring themselves, but potentially high reward, would be really beneficial as well, because I've noticed a lot of women move away from wanting drug interventions and things like that. So if you've got holistic things, that would be incredible, that are very targeted. That would be really beneficial, I think, to the platform.
Yeah, for sure.
Yeah, thanks. Nusrat.
Thanks, Lauren and Sophie, for the wonderful presentations. It's so nice to hear all the work you're doing. Just to give you context, I have been working in maternal and newborn health, but from a global health perspective. And I'm particularly interested in the UK context, especially early pregnancy unit and early pregnancy loss, and so how women cope with their physical and mental health during this time, and evaluating those services. But I'm not coming from a clinical background. So I guess my question is, for someone who's interested to do this research in primary care setting in the UK, how do we go about kind of finding collaborators or even units who would be interested in connecting and in doing this work?
Do you want me to take this one, Sophie? It's EPU.
Yeah, sure.
We actually have an EPU lead on the call, but I'm not going to shout them out. So I'm sure her ears have pricked up. She doesn't have video as she's on the train. Within the trust, you would have a lot of women because we have an exceptionally busy early pregnancy unit, and you can contact me offline and email me about strategies. There's also a lovely GP who Ben and Rowan put me in touch with, who is doing an academic element to her training, and she's very interested in women's health, so she would be a good person to connect you with. And I think her practice she's working out of is in Acton, and she's training under Imperial, so she may be incredible. And one of our lead consultants here leads the recurrent miscarriage clinic, and she's the North West London director for maternal medicine as well. So I'm sure that she would have some insight as well, because she does a lot of pre-pregnancy planning, which I think would tie in beautifully with what you do. And my colleague and I, Miss Noons, also did a quality improvement project at West Middlesex using virtual reality headsets for women having pregnancy procedures in the outpatient setting when they'd had a delayed miscarriage, to try and help their mental health and pain outcomes. So myself and Natalie, because I can see she's put her lovely hands up in the chat, we would be more than happy to discuss with you, because we do believe it's a really beneficial area. We need to treat trauma like a fire and make sure it doesn't spread. We just need to try and get that support in nice and early. So I'd be interested to talk to you further if you want to.
I'll drop you a message afterwards. Thank you.
No worries.
It's what's so great about this network, isn't it? Connecting across. Yes. We have only just a minute or so left, so I'll say thank you so much, everyone, for coming. Thank you so much, Lauren and Sophie. That was excellent, beautifully presented, wonderful discussion. Our next QIN is on October the 20th, and we're going to have a little bit of a look at the current state of QI research. So kind of just looking a little bit about what's happening out there, the research that's out there. And we look forward to seeing you in October. Again, it will be a short presentation and then a good chance for a discussion on that kind of topic. Thanks very much, everyone. Thank you. See you later.
Thanks everyone.